Rebecca asked me to talk a little bit about the work that we do through the U of M Injury Center, and then on the end I'll tag on a little bit about the specific work that, that I'm involved in. But the U of M Injury Center was funded as one of 9 CDC-funded injury centers in 2012. It existed long before that within the Department of Emergency Medicine, but really broadened its scope through obtaining CDC funding. And the current injury center is organized into 4 specific cores. The largest of the cores is the research core, and we'll talk a little bit more about the different projects and how they fit into that. There's also a training and education core, an outreach and translation core, and then within the cores there's some subgroups, a statistics and methods group that really works on improving the methodology of some of the research we do, and then a policy work group that works on taking some of the research and advancing policy-oriented goals or informing policymakers about the effects of the research. Within the framework of these cores, the admin core helps to sort of grease the wheels of everything and make it all work. So this is really a multidisciplinary center. It involves researchers from the medical school as well as the School of Public Health, the Transportation Research Institute, as well as many other areas on campus, social work, engineering, kinesiology, nursing. And there are a number of focus areas, although we focus broadly on injury. We have some specific portfolios in prescription drug misuse, young driver safety and driving safety overall, violence, including both youth violence and campus sexual violence, and then sports-related concussion. So I thought I would take a brief tour through some of the different areas that the Injury Center does focus on. So in the area of prescription drug misuse, many of you were around for Amy Bonhart's recent talk. The work that she presented was an intervention study that was funded through the Injury Center and took place here in the emergency department on developing an intervention for patients who are at risk for opioid overdose. As well as that small research project, we also have funded a number of pilot studies and held a full-day summit, which brought in nationally recognized speakers on the topic of prescription drug misuse. And through that process have actually started to work on a number of projects that were outgrowths of that, including a research project involving some members of our department to improve the quality of the MAPS data that we get, both real-time in the department as we practice clinically, but then also access to it from a research capacity so we can really understand the problem within our state. And for those of you who don't know, there is a provision in the law around MAPS that prevents us from currently using that data for any research-oriented goals. So we're working to change that. In the area of young driver safety, we have 2 current center projects focused around this topic. One is an intervention study looking at testing the efficacy of a parent guide for coaching teen drivers. And some of you who have teenage drivers may have come in contact with this as you go through the DMV program. And then we have a policy-oriented study that is looking at, and it's just getting going, it's looking at spatial and place-based factors for teen crashes and how those factors may have changed with the graduated driver licensing laws that have been implemented throughout the state of Michigan. There's also been a number of funded pilot studies in this area. We also have some research that's gone on complementary to not just young driver safety, but in the area of policies around alcohol-related driving. We had a paper that came out on looking at installing mandatory ignition interlocks throughout all vehicles and the effect that might have throughout the United States on alcohol-related motor vehicle crash fatalities and injuries. Within the area of violence, many of you know the Safer Teens study, which was done at Hurley, which was a successful violence intervention for teenage youth who come in through the emergency department with a history of alcohol and fighting. And the center is actually working on taking that project to the next level and translating that successful research into a package that can be disseminated out through emergency departments. It's a package that involves a website with training materials and a way of getting that research further out than just the single center study that was done. And to augment that, we're also doing both a hybrid effectiveness and implementation trial, also being done at Hurley to look at some of the pieces of that we're doing to enhance the original research. Also through the center, we've had a project working with the pediatric residents on improving their screening within their clinics for firearm safety among parents who have firearms in the home, and have developed a educational tool that the residents can use when they're doing anticipatory guidance in the clinics. Some newer areas of focus for the center are around sports-related concussion and campus sexual assault, and these actually grew out of pilot studies that were funded through the center. And the sports-related concussion work has led to another national summit on the topic, as well as policy work and several more funded studies within the area of sports-related concussion. And then the campus sexual assault prevention, as many of you know, this has become a very significant topic, especially at Michigan. And a pilot study done through the center is actually leading to work that's being done currently on developing an intervention and testing that intervention. So overall, the center has funded about 25 pilot studies to date, and about 50% of those go on to external funding awards. There's been more than 8 grants funded so far. And in addition to supporting not only pilot studies, there's a research roundtable that's done through the center that allows investigators who are funded through the center to interact and exchange ideas. And then there's through the Outreach and Translation Corps, we are able to kind of get out a lot of the data about some of the projects that are being done. And through the Training and Education Corps, we're also train a whole host of people through the pipeline of students here at the university, from the undergraduate level through their involvement in research programs, grad students who come and do internships in the center in the summer, as well as postdocs and graduate medical education level through to junior faculty who get mentorship through the center and senior faculty. And then there's also been, we've developed as part of the center work a certificate in injury science through the U of M School of Public Health. All right, sorry, that was a quick tour of the injury center work, and I thought I would just talk briefly about some of the work that I've been focusing on. My interest is in youth violence, and it's in a particular segment of youth violence, those kids who are at the highest risk for death from firearm-related injuries. So we know firearms are the second leading cause of death among youth populations 14 to 24, and that there are significant disparities in the deaths from firearms. They're predominantly among African-American youth, specifically in urban settings. And the mechanism for that injury is usually, in most settings, homicides or assaults. We know that substance use is a significant factor for firearm-related injury, as well as behaviors, including firearm possession and carriage. Substance use has been associated with aggression and victimization related to firearms. So one of the questions I often get when I talk about this work is, why focus on youth in the emergency department? Well, we know in urban settings that, that the emergency department can be a critical access point for these youth. 1 in 4 urban minority youth do not have a primary care physician and do not attend school. And their interaction with the system is actually, before they enter the criminal justice system, is actually through the emergency department. And we know that in 2011, more than 900,000 youth were injured in a violent injury and required emergency department care. So this may be our only opportunity to intervene before these youth end up either with a fatal injury or in the criminal justice system. We know that the current standard of care for assault-injured youth is inadequate. For a whole host of other diseases, Bill talked about stroke this morning, we look at ways of preventing the risk factors that affect negative outcomes. But for kids who come into the emergency department for an assault, we treat their wounds and we discharge them, and we don't currently have a good standard of care for preventing them from coming back for a repeat injury or for more fatal injury. So as I talked about a little bit earlier, there's the Safer Teen study that went on at Flint, which was a successful intervention using basically behavioral counseling that used motivational interviewing and cognitive behavioral skills training to decrease peer violence. And the effects that they saw from the trial were that peer violence were decreased for up to a year. So, but what we do know is that those effects were modest and dissipated over time, and that for higher risk youth, that may not be enough, a single session intervention. So what I was interested in looking at, and what I'm looking at in my K grant, is whether or not a multi-session intervention with behavioral therapy can be a better intervention for higher risk youth, such as those that are at risk for firearm injuries. And then building into that, the question for multi-session interventions that can be started in the emergency department and continued afterwards is is whether or not these sessions can be done remotely to take advantage of the fact that these kids don't have abilities to get to the emergency department again for transport, or can get standard intervention during business hours. So we're looking at trying to do those interventions from a remote setting over the telephone, as well as using technology to augment the delivery of those interventions. So the current grant is a two-phase grant. So we're, phase one, we're testing the feasibility of using a smartphone app to collect daily data on both substance use and high-risk firearm behaviors among kids who come through the emergency department who both have a history of substance use and a history of firearm possession. And the purpose here is twofold. One is to test the feasibility of collecting this type of intensive longitudinal data on these patients, as well as, second, to understand the interplay between certain cognitive factors, their moods, their affects, their motives, and their substance use and their use of firearms. And then the second phase of the K grant is to develop and pilot test a multi-session intervention for these kids. The proposed intervention would include multi-session behavioral therapy that involves motivational interviewing and cognitive behavioral skill testing, and would involve support of a smartphone app. And that app would both facilitate contact with the therapist, as well as deliver tailored positive behavioral messages, and also allow for GPS-guided feedback on to the youth as they go into high-risk locations or have high-risk behaviors. And outcomes that we're going to be looking at are substance use, high-risk firearm behaviors, and we'll also look at a host of criminal justice outcomes. So that was kind of a quick tour, and I'll stop there. And questions?
So I think we can take questions. I'll just note for Dr. Carter, so many of you may have heard that the federal government is slightly hesitant to fund firearm research. We believe Patrick has received the first firearm-related K award in the country, and some of the first funding from the NIH in 20 years. So this was awarded this week, and the mic is dead, but we're very excited. So questions?
So I'm fascinated by the strategy of using the app for that continuous engagement of the whatever kind of patient that leaves the emergency department. What resources do you tap into to do that? Because that's an area where there's a lot of potential synergy across all of our programs of how we can follow patients after they leave the emergency department and prevent readmissions, prevent exacerbations of chronic diseases and so on.
In terms of designing the app, or in terms of?
Yeah, I mean, is it through, designing and testing, and who are you working with to do that?
So the Center for Health Communications Research is here on campus. So it's a multidisciplinary group that does research related to both smartphone apps as well as other technological interventions, texting. We're actually working with them currently for I talked briefly about the translation portion of the Safer Teens study, and for that study they've built a automated texting program, so these kids can interact via text, and they get feedback that's tailored to them based on the survey answers that they gave that are positive messages, as well as they can interact by texting to the program, that they need an additional message, and then the program automates it and tailors it to their specific responses. So we've been working with them for other studies, but specifically we'll be working with them for the development of the app and these components of the app. And they do research across campus on a multitude of different projects and types of projects.
Congratulations on the K.
Thank you.
So given the federal government's resistance to, or aversion to, funding this type of work, what was it about your proposal, do you think, that made it get through?
I think it's a combination of factors. I think, the shooting that occurred at Newtown in 2012 certainly changed a lot of things. After that, President Obama submitted a mandate for folks to start doing research in firearms again. The CDC has been the most hesitant in responding to that, but the NIH has actually been more active in trying to support that goal. So they reallocated some funds towards towards supporting firearm research specifically and released RFAs around firearm research. In terms of K awards, this is, as Rebecca said, I think the first one funded on firearm research. There were a couple of RO1s that have been funded with some researchers out in California who've done firearm research for a while. So I think there's a little bit of a movement towards funding this type of work. Whether that will continue, I don't know.
It will continue for the next 5 years for this award. So, other questions?
This is not directed to the science so much, but I think one of the things that might be helpful for people, for you, and I'm sorry I didn't get a chance to ask Keith too, a very brief story of how you got, were you interested in doing research when you were a resident, and how did you end up where you are?
So I don't think I had an interest in doing research, and I sort of got here by a tortuous path. I think when I was graduating residency, my interest was more in global health, and Bill was kind enough to offer me a job, and I worked on the Ghana project for a number of years, and then through that met Rebecca, and she sort of planted the research bug, I think, and kind of sucked me into her injury-related research world, and that's how I got interested in that. And I ended up just started looking at some data that she had on firearm possession among kids who come into the emergency department with an assault injury, and we found that a quarter of them had firearms, and 80% of those were obtained illegally, and they were at high risk for repeat injury, and that kind of, from there, got my interest.